My name is Shirish Gadgil. I'm the Chief of Division of Hematology Oncology at Henry Ford Cancer Institute and Henry Ford Hospital in Detroit, Michigan. And it's my pleasure to join with Dr. Neil Reddy from Medical Thoracic Oncologist at Duke Medical Center to discuss a very important topic of managing lung cancer patients, particularly advanced lung cancer patients in the era of COVID-19. Over the last, I would say, 5 to 6 months, both our personal lives, but particularly our professional lives, have been altered with the onset of this pandemic, which is ongoing. And the biggest factor that has impacted our practice is the unknown. We have learned about the pandemic as we have gone along, and that has tremendously impacted our practice. And I think lung cancer patients are a particularly susceptible population to have complications as well as high mortality rate from this infection. So we are going to discuss today our own sort of practices in managing lung cancer patients, particularly advanced lung cancer patients in this pandemic. So Dr. Reddy, could you sort of share your thoughts on this issue?
Thanks very much. I think that all of us are struggling with how to manage patients who need treatment because they have a life-threatening illness. So it's not something we can defer 6 or 12 months. But how do we do that in the safest way possible? At our center, we've been doing what we can, just like out in society, to mitigate risk. So how do we mitigate risk? So we have tried to decrease the number of patients coming into the clinic. We have a significant number of patients who are on oral therapy. And once they've been on oral therapy for a few months, they are often doing really well and don't really need to be seen in person. So at the beginning of treatment and then later on, we will often have patients just get laboratories at some commercial laboratory nearby, fax us the result, and then we'll do a telehealth visit where they don't have to come in and run through the gauntlet of the cancer center or the clinic, stop at the lab and do all those things and potentially get exposed. And then we might see, rather than see them once a month, we'll see them every 3 months when they come in for a CAT scan to make sure that they're doing okay. I think that we have tried to defer testing on patients who are on follow-up. So if a patient is on follow-up after treatment for early stage lung cancer and they're having surveillance CAT scans done, every so often, we're extending that period. So if we were planning on having them come back at 6 months, now we have them come back at 9 months. If they were on yearly follow-up, now we have them come in at 18 months. So all of these approaches are trying to decrease the number of people in our laboratory, in our X-ray center, and in our waiting rooms to decrease the risk of patients to each other and patients to the care providers, who then are seeing other patients and could expose more patients. So we're doing all of that. We haven't seen a big impact on our infusion rooms. So whereas our actual in-person visits are down by 40 or 50%, our infusion unit has been running about 80 to 90% of its usual capacity because, again, these people have life-threatening illnesses and they need to come for treatment. One of the things that's been a big help is for patients who are stable and doing well on immune therapy. We can typically go, rather than every 2 weeks, every 4 weeks now, and sometimes every 6 weeks now. So we typically will see patients for 3 or 4 cycles of treatment every 2 or 3 weeks to make sure they're doing okay, to make sure they're not going to get a toxicity, because that's the time period when you'll see most of the toxicities. And if they're stable on immune therapy out 3 or 4 months, then we'll go to every 4 weeks or every 6 weeks, so they just don't have to come in as often. Professor Gadgil, what has been your approach?
Very similar. A few other things. Some of the challenges that have come up is that we have limited the number of family members that can accompany the patients, and particularly I think for lung cancer patients who can be elderly and have comorbid illnesses, it can be a challenge. We have made accommodations where possible, but that has definitely added to sort of difficulties of managing these patients. Our screening criteria have evolved. We now have twice we screen patients the day before, the day of the visit. We're looking at some other approaches. There is in a small sort of a pilot effort, we have initiated a home-based lab collection. So instead of the patient going to a lab, a nurse goes out and collects the labs, also does the vitals, so that certain visits can be limited. And then the other thing is what is to come, say later this year, particularly in the fall. And so now, as I'm seeing the patients, some of the patients actually that I would have seen maybe in 6 months, I'm trying to see if I should see them a little bit earlier, just to maybe before that expected surge in the fall, or the second wave, as they're saying now. Who knows if that will occur, and if it occurs, when exactly it will occur. So, but I would say that we all have to start thinking much more about these factors in sort of charting out the treatment plan, the management plan, the return visit plan for our patients, and we will see how it evolves. We have very limited data regarding managing patients who have COVID-19 and cancer. At the present time, they're being managed as non-cancer patients, even though we are aware that there is a higher mortality rate in these patients. It's not clear whether that is related to the underlying cancer, or there is a higher rate of comorbidities that these patients have, such as cardiovascular issues, renal failure, diabetes. Nonetheless, they clearly have a high risk of mortality. But at the present time, the management of these patients is no different than the way COVID-19 patients are managed who don't have cancer. But I think this is something that needs to be followed by all oncologists very closely, because data is emerging fairly rapidly. And standards of care, both for screening as well as management, will evolve, and one needs to be mindful of that. So thank you very much for attending this session today.